I think we can go ahead and get started. We have a lot of our residents here and a couple more will probably trickle in, but
Great.
I'm happy to introduce Dr. Stephen Morris. He's one of our attendings in the emergency department. So many of you who have done your ER rotations have probably worked with him. We're going to be learning about disaster preparedness and our response and duty as clinicians.
So thanks everyone for coming and listening in. So I've been doing this work for about 8-9 years now. My previous background was in humanitarian aid and international development, particularly focusing on health systems development. So for family and personal reasons, it was important for me to kind of transition from a lifestyle where I was traveling, 4 to 6 months a year to something that was a little bit more stable. And so there's a lot of overlap. And I have a lot of roles. So I have a role at the UW medicine level. I'm currently the staff supervisor for the COVID response. I have roles at the hospital level, so I'm on the disaster committees at all 4 of the UW hospitals. Obviously for my department, I'm the head of the disaster work. Then I have a King County clinical advisory role, and then the same role for Washington State. And then finally, I work for Health and Human Services. So I've got my hands in a lot of different disaster related pots. So this is probably the most important slide that I'm going to show. And it's that you need to have some sort of disaster planning for your home. So, so you can see it says supplies 2 weeks. So the CDC guidelines and all the guidelines for the different parts of government in the United States says that you need 3 days worth of supplies, with the exception of those people that live in Seattle who need 2 weeks. And the reason that we are such an exception is because when we have our big event, which will happen, which will be an earthquake, there's not going to be anybody that's going to be able to come to us anytime reasonably soon. And I'll talk a little bit more about that. But this is important. You should have stuff. So a disaster, I'm using the United Nations definition here, but a simpler way of disaster, thinking about disasters, anything that disrupts the normal functioning of an entity. So in our case, anything that disrupts the normal conveyance of healthcare delivery is considered a disaster. So we can even call disasters when, say, in the emergency department, which spreads to the whole hospital and can spread to the whole healthcare system in the region of Seattle, when we have something like a mass casualty. And a mass casualty is really whatever we think is going to overwhelm us at that time. So if it's a Monday afternoon, or worse yet, if it's a Friday afternoon, all the clinics are closing, everyone's being pushed into the ED, and we have a 5-car pileup, that might be enough to call a disaster code. Now there's different levels, obviously, but just think of disasters in terms of overwhelming the response or ability of an organization to respond. So today, we'll look at why you in particular as clinicians should be invested in this. I'm going to speak a little bit about the definition of disaster medicine and how it relates to healthcare emergency management. And then a quick look at our local environment, some local disaster preparedness issues, and then some lessons learned. And I've mixed those last 3 up just so it's a little bit more interesting. So why should you care? So first of all, people think of disasters as these unpredictable things that won't happen to them. And that's just the opposite. First of all, they're very, very predictable. And we'll talk about that in an upcoming slide. And second of all, you will be affected. And I think now with COVID, people realize that something's going to happen to them eventually. We all talked about something like COVID. We're all extremely thankful it's not a disease like Ebola, because then things would be even significantly worse than they are now. And I think in the long run, something like COVID has both, it's going to have good and bad. There's going to be a silver lining there. And interestingly enough, within our field, and I'm getting a little off topic here, as is my nature, we're talking now about the fact that COVID will probably kill a lot more people by the effects of how society changes on a disease. So some big things to think about that are going to be the big killers from COVID are the increase in poverty. right? So if you look globally, poverty is kind of the main killer. And so poverty is going to increase from COVID, and it's certainly going to eclipse the number of deaths that we're seeing from the specific disease itself. Another thing that I think is also critical to realize is we now have this entire population of young people who are not building immunity, right? No immunity without exposure. We now have kids that are not getting exposed, which means they're not going to have immunity, which means they're going to be affected by disease. Anyway, off topic, those are interesting things to think about. So, so it's going to happen to you, you'll be affected, and it's predictable. Additionally, as healthcare providers, you're disproportionately affected, as is the health system. So what do I mean by that, right? So what I mean is that you're going to have increased injuries and illness, right? Your infrastructure, which you rely upon, is going to be, severely damaged. There can be a car accident right in front of me. I'm an emergency medicine provider. Actually, that's not a good example because I have a pretty badass medical kit in the back of my car. But I can be walking along and there's a car accident in front of me and I can't do much, right? I mean, I can take my shirt off and hold pressure on the wound, but I need stuff to do my job the same way you guys need stuff to do your job. So damage infrastructure and supply chains is a big one, and we've learned a lot of lessons around supply chains from the COVID response. And then, of course, healthcare workers are affected just like everybody else. I'm going to flip back to this first slide about disaster preparedness in the home. So I do this for a living, right? This is, my bread and butter, but, and I'm going to be, I intentionally live very close to the hospitals, but I can tell you that if my family is under threat and my family is not safe, I'm not showing up, right? And so part of this being prepared is that I can go and fill my role for the rest of society. And the same thing goes for you guys. So, so healthcare workers are affected by the event and emotionally and physically, just like everyone else. And then there's the quadruple threat, which is that we share other people's grief. And we do this all the time at work anyway, but hopefully we're in a good mental state when we are sharing other people's grief on a day-to-day basis. During a disaster, we might not be, having lost loved ones and friends. And I've worked with in a lot of places where healthcare providers have died, and that's during an event. And that's really, really hard for people to get over, having their coworkers die. I wouldn't say more hard than having their loved ones died, but it's just an added layer of nuance. So here's some examples from my work in Puerto Rico, or the event in Puerto Rico, I should say. So increased volumes from injuries, increased GI and respiratory illness. The GI and respiratory illness is a big piece that people don't necessarily think about when they think about events. When you have an earthquake happens, or your building is unstructured, you're not living in your house afterwards. And so either you're living outside in the cold and exposed to things, or you're living in a group setting, which obviously exposes you to GI and respiratory illness. The clinics were closed, the power was disrupted, there weren't very good supplies of medications and deliverables. And then interestingly enough, many of the healthcare workers left the island. They left the island because they could, and they knew a big hurricane was coming, right? And so they need to protect their family and their interests as well. And they had the means, whereas the people that were left often didn't have the means. So there I am. One of the cool things about doing this work is you get to walk out on the tarmac and wear this fancy outfit without having to hold a gun, and so it's kind of fun. In terms of Puerto Rico, one of the other things that was interesting was there's something like 87 or 100 Burger Kings on the island. All 100 of them were open the next day and supplied because they have flexibility where the government and other institutions don't have flexibility. Burger King could just say, well, we'll buy extra supplies. If they go bad, well, we'll lose, but if we use them, we'll make a lot more money. And they did. And every Burger King had a generator and every Burger King had gas. So we can learn lessons from other parts of society. So in terms of the predictability of disasters, there are there are a number of things that are just givens, right? First of all, before the disaster even happens, people are going to resist training, right? I appreciate that you guys are listening to me this morning, but in general, when you tell people that there's going to be a disaster drill, people aren't very excited about it, right? They want to keep doing their regular job. They don't want to be distracted, etc. Plus, they're preparing for something that's an unknown. So it's inherently undervalued entity. And so there's going to be this resistance. Another guarantee is that an earthquake's going to destroy Seattle, right? I hope it's not during my lifetime, my kid's lifetime, et cetera, et cetera. But it's going to happen. It's happened in the past. Our geology shows it, et cetera. Hurricanes are going to hit the East Coast in the fall. You know, they're also going to hit the East Coast of Asia around the same time, called typhoons. So these things are patterns that we can predict. Injury patterns after an event are very predictable, right? After an earthquake, you're going to have crush injuries, and that goes to medical issues as well, and I'll talk about that in this slide. So some unpredictable things, timing and intensity, right? So the next earthquake that hits Seattle, maybe it'll be really big, maybe it'll be medium, maybe it'll be small. We can't really predict that very well, although we're getting a little bit better. Terrorism, this is a big unpredictable one, and it's really hard to plan for, other than making your health system as robust as you can at baseline. And then structural and equipment failure. These are things that are predictable in terms of the force, but there's a lot that goes into whether or not things are going to work in terms of your planning. So, so along the lines of structural failure, so I mentioned that, you know, when there's an earthquake, you're not going to be inside your house. Same thing with the hospital. Even if that hospital was totally safe, those patients would not allow themselves to be put inside, right? Because they're traumatized by the event. And additionally, when we talk about building safety, just because Harborview is very highly rated and we've spent, you know, tens of millions of dollars, if not hundreds of millions of dollars, making it structurally sound. By the way, the walkway over 9th Avenue, that's a structural entity. That's not for to make it easier for you to connect from one building to another or to look pretty or anything. That's to keep the two buildings more stable. So even though those buildings are very structurally sound, it doesn't mean that you can use them as hospitals afterwards. The rating is based on how many people will die in the building during the event, right? So will the building be able to be used at all? Will it be able to be used as, you know, as the building was intended to be used? Those are very variable. And, you know, if a big one hits in Seattle, we probably won't be using our hospitals for hospitals. We might be using them for something else, but probably not for hospitals. So the other thing that's very predictable is this cycle of disaster, right? So so you have the hazard event, which would be the earthquake or the storm. That we describe that as the risk. And a lot of this terminology is a little bit challenging. And I will say that despite the challenging terminology, there's been a real push to make this homogeneous in terms of different agencies using different terminologies. So you have the event, we respond to the event. That's the very cool part, right? That's me standing on the tarmac in my fun little outfit. And that's actually pretty short-lived in general. Then we have the recovery period, right? So now in the COVID response, right, this response and the recovery right now are kind of intermingling. They're going back and forth. And I would say even prevention and mitigation, all of these things are missed because this is such a long-term event. It's something beyond our normal capacity. And then we prepare for the next one. The mitigation, we take our lessons learned and we kind of adjust the way we do business. And then hopefully we're better prepared. And then we just wait. We wait for the next event to happen. So, so these are some pictures of me in Haiti. I blocked out my face because I'm smiling kind of weirdly. I was smiling because someone was taking my picture, but it doesn't really look nice given the destruction. That's actually the Capitol building behind me. And then this is from the hospital. I was the medical director of a 1,200 bed, in quotes, field hospital. We were the main post-surgical hospital for the ship, for the Navy ship, the Comfort. So they would operate on patients, and then they would come from the PACU to a helicopter, and from a helicopter to me. I would triage them, find a place for them, and then we would manage them until discharge, unless we had to send them back if they got sick, which happened. So in terms of the concept of disaster medicine, this is a quote from the author of kind of the main text that defines the field. It's a mix between emergency medicine and disaster management, and I'll go into this now. Another way to put it is that it's a clinical subspecialty that encompasses a combination of medical aspects, but also a combination of non-medical related fields. So from a clinical medicine, some of the things that we have that are important are the ethics of managing these disaster events, which I think we've seen very clearly that there's a lot of ethical considerations around COVID, limiting care. By the way, we talk about this stuff all the time. So, in terms of limiting care, we've been working on a plan for this in Washington State for over a decade. So these things are kind of, it's new to a lot of people, but it's not new to us. The concepts of triage and surge capacity, we've been focusing a lot on surge capacity over COVID, but it's a different kind of surge capacity. Usually when we're talking about acute events, our surge capacity is like, how do we clean out the emergency department? How do we clean out the operating rooms? How do we clear out the ICUs? Knowing that in 2 days it's going to be better. Now it's like, how do we anticipate the coming surge? Utilitarian theory, this is a change where you change your concept of patient care from a single patient to a population. And that can be hard for people that have done this their entire life, right? Patients first, what's good for the patient, that changes, and it can be hard for clinicians. The concept of safety, provider safety, staff safety, this is hugely important. I had mentioned the effect of having a coworker die during an event. That has a much greater effect on, or a disproportionate effect on, the ability of the institution to provide care than other things. And I saw that. I go to Vietnam every year, and they lost a lot of healthcare providers during H1N1, and they've not recovered. I'm sorry, during swine flu. Sorry, years and years ago, they've not recovered from that. So it's really tough. We actually see that in the emergency department when our staff get assaulted. It really just changes the whole nature of the way we're able to do our job in a negative way. There's a lot of structure around emergency management and response systems that are part of clinical medicine, that intertwine with clinical medicine. And then the concepts of risk, threat, and hazard analysis. How do you figure out where your structure is going to be most affected? And so emergency management as a field encompasses all of these things. It's progressive. You want to think about it beforehand. It's risk-driven. You don't want to start thinking about an earthquake when you're in a place that doesn't have earthquakes. It's integrated, so you need to make sure that the hospital is talking to the city, who's talking to the state, and everyone gets along well. I will say that the ideal is when there's an event happening at Harborview, although we go through all of these formal formal ways of communication, the best thing is that if the head of the emergency department picks up their phone and texts the head of the other emergency departments, and that we've done that in Seattle. We're really good at that, right? The CEO of UW Medicine, picks up their phone and calls the CEO of Swedish, and that kind of communication is very important. I will say that was one of the big things that happened in New York with the very challenging thing is that those having lived and worked there, those institutions have a really hard time communicating, and they don't quite have that collaborative, hey, this is a disaster, let's all work together for what's better for society kind of approach. They probably will now, I'll just say that. So collaborative, we all work together, coordinated, good communication, that flexible, so we'll do whatever it is, whatever it takes, and then we try and use science, which, enough said. So some medical examples of medical aspects of disasters. So obviously an involvement of different groups. So orthopedics, saw a lot of that in Haiti. General surgery, we see that with civil unrest. My humanitarian days, that's big. Obviously you can't do orthopedics and general surgery, can't do anything without either anesthesia or myself being able to sedate the patients. ID, I mentioned that with respiratory and GI illness. And then in all disasters, you know, there's people like me that are, and family medicine and these kind of broad specialists or broad generalists. Psychology is a big one. And then pediatrics, geriatrics, internal medicine. So some clinical aspects from my work in Haiti. So early what we saw was things like the orthopedic injuries, the crush injuries. We also saw some early metabolic issues because people didn't have access to water or they were crushed and they really didn't have access to water. So we dealt with a lot of kidney failure. The general surgery and emergency medicine laceration, you know, complex laceration, you know, infected laceration, that was big. It was a lot of work. A lot of blunt abdominal injuries, and then neurosurgery, which, you know, unfortunately, those people did not do well. Right in the middle, kind of after the first week to 2 weeks, you know, then we started seeing things like PEs, you know, continued metabolic disease, a lot of chronic disease that was never treated or had previously been treated okay, but now was completely you know, undertreated. DKA, I should have added to that list. We had a lot of people came in DKA. And then late, we had to deal with things like, you know, prosthetics and rehab, you know, OTPT. And then I should add to that, the late one, the huge one for us was social work, which I think I mentioned. So on the left top, that's my, that was my triage tent. So patients would come through there, they would bounce back whenever they were identified as being sick. On the right is a Sunday church service, obviously very religious country. And we were, the land we were using was a religious organization had donated the land and a lot of money for us to get our hospital up and running. And then on the right, you can see we're standing on the helicopter, or on the bottom helicopter pad looking down at the tents. I'd like to, anyway. So non-clinical aspects of disaster medicine are things like health system surge, which we've mentioned. Also meteorology, like a lot of weather kind of prediction stuff, earthquake prediction stuff, and engineering related to that. You know, even the engineering and the structure of the hospital, you know, a lot of my prior work in health systems development, you know, how do the different parts of the health system interact? And then military science as well, right? Blast injuries, force of injuries, things of that nature. So some non-medical aspects of my work in Haiti were unaccompanied children. Huge deal for us to manage, you know, unaccompanied children. You know, at times I would have 60 kids, no parents, no relatives, no nothing, right? Very, very vulnerable. You know, wash, water, sanitation, food, these things were also very important. Security, I can flip back to the unaccompanied children. You guys might remember that there were groups from the United States who were actively going to the disaster area and kidnapping children. A lot of them got caught, which was good. But, you know, our security was you know, was robust. And actually we worked very, very closely with a number of organizations, the UN and federal government to help with security. Discharge planning and coordination, that was what I was saying. Social work was a huge deal, right? You can't send someone with a big open wound back to their destroyed house with no access to water and no access to food and they're on crutches, right? Or someone with bilateral femur fractures, right? Who can't ambulate, can't go back to, you know, their destroyed society. So that took a lot of work. Plumbing I threw in there because we had a terrible plumbing problem one time and, you know, and we're standing around, there's like 40 of us standing around and I announced, hey, you know, we've got this plumbing break. We're going to have to start using buckets of water and this and that. And, you know, one of the nurses raises his hand and says, I'm a plumber. So people have skills outside of their normal, you know, skill set. And that was very helpful. Staff management was a huge deal, especially for me. I had like up to 200 staff, and so I wasn't quite used to that. And of course, every staff member is under a lot of stress, and so making sure that people are safe and able to do their jobs is a big portion of the event. And I mentioned this, the reversal from personal population health. There are some entities that are not covered in anything else as part of medicine, you know, CBRN, which I'm happy to talk about if anyone's interested. I do a fair bit of work on that. And then disaster psychology, also a big field. And then the medical stuff, which are the military stuff is a different. So, you know, it can be really hard work, obviously, and from an emotional, from a physical standpoint, you know, it's not work that is cut out for people to do all people to do all the time. I think it can be very rewarding, though, for people that are in medicine to at least try at some point. They may love it, and it may become a big part of their career. So. So a local example, just to break this up, so CHOP, which was, you know, the Capitol Hill organized protest. So was this a disaster? I've been asked before, and I would say it was. And the reason it was that it affected the normal function of a lot of institutions, right? It affected and continues to affect the safety aspect of our city. So if you look at something like police response times, if you look at something like response to violence times, those things have all changed after CHOP. And then it disrupted healthcare. You know, it disrupted EMS. And I'm not putting political judgment one way or the other. I don't really care. But, well, I mean, I do care, but it's not related to this talk. You know, so anything that disrupts a normal functioning is considered a disaster. And then there was some increase in the burden of disease, particularly the violence. And then there were a lot of people that came in from out of town in a way that was markedly different from visitors from out of town. You know, normally our visitors from out of town are tourists, right? These were visitors from out of town that didn't quite have the infrastructure to be self-supportive in some ways, or were not able to, or did not come necessarily with the ability to manage all of their healthcare needs. I don't have data on that. It's just a discussion. So I put this picture up there because these are the medics, right? And so it's a bit of a conflict of interest. If you look at that gentleman on the left, I presume it's a gentleman, but I'm not sure. You know, he's got the medical bag on his hip, but then he's holding a semi-automatic rifle. So, you know, when you're working in zones that the rule of law is kind of marginalized, you end up with situations where there's a lot of conflict of interest, right? We see that in places, you know, where, you know, in a much subtler area where the doctors own the MRI scans, right? And there's MRI machines and there's a conflict of interest. So, but this was pretty blatant example from here in the United States. Civil unrest tends to be less predictable than other things. Some elements that are predictable is that you can get crowds and poor infrastructure, and then it's going to affect other things. What's not predictable is the timing, the violence, if there is any, hopefully there's not, and then how long is it going to last. So some local examples of disaster preparedness, switching back to sort of the mainstay of the lecture. So, so after 2011, there was this development of these concepts called the healthcare coalitions. And these are entities that are all around the country that are partially funded locally and partially funded federally, that work to homogenize healthcare delivery in one area. So they help the different EMS systems and the different healthcare delivery systems at all levels work together with regards to disaster. So, you know, I mentioned the heads of the hospitals. Once a month, the heads of the hospitals get together and talk about disaster over breakfast. We, as people that are clinical advisory folks, you know, once every 2 months, we get together in the afternoon over, over coffee and sit around as a group, people from Swedish, from Virginia Mason, from Madigan, from TG, all of these different entities as well as some from outside the normal blocks. So, representative of the post-acute care world. And we talk about things and sort of plan and work through things like our surge plans and and our communication. And that's really what the Healthcare Coalition is doing. And it's kind of a behind the scenes thing that happens everywhere. So there's a lot of variability in terms of how much preparation is done. Seattle, we're not typical because it's important to us. But we have, the Department of Health, King County, which is a very, very robust institution compared to other cities of the same size. We have the Coalition, which I just mentioned. It's got a ridiculous name, Northwest Healthcare Response Network. And the Coalition does training, coordination, guidance, and then they act in the event as kind of an overseer. And then there's usually an entity that sort of takes the lead from a healthcare delivery. And in that case, in our case, obviously it's Harborview that plays that role. So some local issues we dealt with COVID, for example, were load leveling. And we saw that at Evergreen, where in the very beginning, Evergreen got crushed. And when that happened, everybody was like, well, that was our one mistake, right? We're not gonna let that happen again. So now there's a very strong infrastructure for load leveling at both the EMS level, the ICU level, and then the floor emergency department level. Not only for critically ill, but as kind of all comers. And we've done that for other things on a regular basis. It was just, this was a unique entity that, we had to adapt to. Rationing and distribution of supplies, that was a big learning lesson. We've done a very good job of that, I think. We're, as the state institution, supplies aren't really, as much of an issue, right? So you can imagine if there's supplies coming into the state and the choice is give them to Virginia Mason and give them to the University of Washington, we're always going to get chosen. So from our clinical standpoint, we should have enough, but we need to make sure that the other people don't. So I don't know if you guys have seen that. One of the other quotes that I think, and this is an interesting article, it's from the Atlantic, I think, or the New Yorker. It's fairly old, like 5-6 years old at this point. One of the better quotes that I heard was that the earthquake on the Cascadia subduction zone is going to be the worst natural disaster in the history of humanity, right? So I think that's more accurate, because we can say that it's going to be worse on the continent, but really it's going to be worse than anything we've ever seen. And you live right in the middle of it. So you should have a little preparation kit. So the hazard vulnerability analysis is what we use for determining the risk of events, like how likely an event is. I shouldn't use the word risk, but how likely an event is and what the impact is. And we kind of balance those two, right? So you have high likelihood events like bad weather that have low impact, right? So bad weather, maybe it's a hassle, a lot more car accidents, etc., but it's not a big deal. You have very unlikely events, right? Like an earthquake, which have a huge impact. And so every year, every institution, we figure these out. And at the state institution, these are some of the things that are known natural hazards. We have something like, 5 dozen, average 5 dozen wildfires or 100 wildfires a year. We have, disease outbreaks all the time. These are guarantees, right? Severe storms every year in Washington state. And some of these are man-made as well, right? So I would add ID, like if we, or excuse me, IT, if we have a major outage of our communication system for the city, that's a big deal, right? But then also dam failures, and then radiological events. So I'm just going to talk through this. Did you guys know we have a nuclear power plant in Washington state? Did everybody know that? Well, surprise, we do. It's called the Columbia Generating Station, and that's a picture of it. It's down kind of southeast near the Tri-Cities. So this is, I'm sure everybody recognizes this, right below Pike Place Market. This is Seattle Steam Company. This is the only production of steam in the downtown core. And as you know from where it is, it's right next to the water. So it's clearly going to be damaged if there's a surge of water. There's something like 270 buildings in the downtown core that will not have power or heat, excuse me, will not have heat if there's steam heat generated. And then all of our hospitals on Pill Hill will not have steam, which we use very extensively. We have a lot of plans around this, right? Luckily, at UW, we have UW Medicine, we have 4 hospitals, so we'll work between each other. Swedish, obviously. Virginia Mason, you know, I'm not sure what their plan is. So where we're all sitting right now, we are sitting on the largest stockpile of nuclear weapons on Earth. About 20 miles from us, the Naval Base has somewhere between 10 and 15, some have predicted even more than 15% of all the nuclear weapons, which I think is ironic given how, you know, ridiculously extremist, liberal our society is, that we happen to be right next to this. So something that is interesting to think about in terms of a vulnerability. So volcanoes, I already mentioned earthquakes. You can see a picture of a lahar there, and then I have intentionally Enumclaw. So Enumclaw is the city on the left, and that's predicted if you know, if there's a big earthquake or the volcano erupts, that Enumclaw is right in that zone where the lahar would flow. So just, it is what it is. I'm not buying property there, but Hanford, which is you know, a very polluted area from our past nuclear development, and so that some people call it the most polluted site in the world. And so I just put a picture of an Olympic swimming pool, so about 112 of those filled with highly reactive nuclear waste. So so we have a lot of things that are making it better. So before we get depressed, so this building is the Office of Emergency Management for the city. Some people say this was the best designed building for earthquakes. It's actually sits on a 4-foot pad of rubber, so it can kind of go back and forth like this, and it has its own power and water. It's super cool. I send my residents down there to take a tour and then make sure that they're done at like 11:30 so that they can walk over and have lunch in the ID, which is right next to it. So we have Boeing, which is a huge entity, and then we have tons of airports. It's ridiculous how many airports we have, which is good. So people can come in and give us supplies. Joint Base Lewis McChord, so 200,000 people. What I like to say is, you know, the best thing about that is there's 50,000 people at Lewis McChord who do exactly what you tell them to do immediately without asking any questions, right? And so that's a lot of stuff. And then, of course, second maybe to Amazon, you know, U.S. military has great logistics. And then we won't even talk about the Canadians, very serious threat, but hopefully they'll stay where they are. And then there's a lot of other things. So we have ferries, we have bridges. I don't know if you guys have ever noticed, but when you're on the ferry, if you look around the ferry, there's often a SWAT team boat that follows you on the ferry, heavily armed SWAT team boat. It's kind of cool. You can definitely see it if you hang out near the waterfront and you watch the ferries come and go. You're like, oh, look at that little boat in the middle of winter with 3 guys with guns on it, or people with guns on it. Sections of I-5 and 405 are actually built on pylons. So half of 405 and half of I-5 in some places will collapse, but we have plans around that. There's nothing we can do about it. Oh yeah, and all of our hospitals are in the same place. It's a little crazy, but what are you gonna do? So hospital disaster preparedness uses I'm gonna try and go fast, uses this system which is standardized for the incident command system. It's the same thing fire, police use in events. It's just a little complicated. And then we're required to do these annual things, right? We're required to have standard operating procedures for the hospital. We're required to have surge plans, evacuation plans. We're required to have plans for power outage. There was a power outage on the East Coast. I want to say about 8-9 years ago. There were 287 hospitals that lost power, totally unpredicted. They lost it in 1 second, and a little bit of pride in the place you live. all 287 of them, the backup power came on immediately. Not a single hospital was left without power. So those people walking around with all the keys on their belt, they actually do a really good job. So, you know, in terms of our COVID response as an institution, obviously there's a lot of lessons learned. We had to adapt our all hazards approach to the COVID event. All hazards approach is a little bit of a term that's hard to, that people misunderstand. So all hazards approach doesn't mean that you plan for all hazards. It means that your planning is such that you can adapt to all hazards. So it's inherent that when you have this, you're going to need to adapt, right? But you don't want to have an earthquake plan and a pandemic plan and, you know, and a pediatric emergency plan. You want to have one plan that's flexible. And it's like the plan you're going to have in your house, right? You're not going to say, you know, I'm going to stockpile beans and rice just in case I'm in the mood for beans and rice when the earthquake hits. But in case it's a storm, I'm going to stockpile lentils, right? No, you're going to stockpile something that you can use versatilely. So there were a lot of challenges that you can imagine. There's still a lot of challenges, by the way, and our numbers are just going straight up. So we're going to have a big peak here that's probably going to be worse than it was in the spring. Obviously, we're a lot better prepared. So we had to build whole new things, right? We had to build, you know, drive-through testing. We had to change our clinics, how they worked. You know, our telemedicine has just been awesome. It's been amazing. Things will never go back. So if you guys hadn't planned on telemedicine as part of your career, well, too bad. It's going to be part of your career. We've had to expand things. You know, there's really only 3 groups that can do ICU level care, right? The critical care folks, anesthesia, and us in the emergency department. And so we had to expand, you know, to think, you know, can we train a cadre of internists? And of course, Andy Lux and others, Trish Critic, you know, stepped up and built this huge curriculum, which is great if you ever want to brush up on your critical care stuff. And then we had to get rid of some things, right? Our elective surgeries. So major challenges was adapting and incorporating isolation. That was a big deal. We had to work on that. How do we ensure the safety of our staff and visitors? That was a big issue. And then how do we change our procedures on everywhere, right? From, you know, how do you move the COVID patient from the emergency department to the floor, to the ICU? You know, back in the beginning, that was a big challenge. And then how do we deal with the lack of masks? And then some subtle things, right? What do you do with the staff member who's 65 or an insulin-dependent diabetic, right? You know, how do you deal with a visitor policy for deliveries, for end-of-life care? These were challenges. You know, what do we do with our transplant patients, right? We don't want them to come into the hospital. We also don't want them to avoid the hospital, right? So there's challenging situations. And then perhaps the big one, how do you do all this without the healthcare institution going bankrupt, right? And the answer is you don't. So if you look at the financial well-being of all of these institutions, really bad. And then we got a lot of this feedback. We're like, how could you keep changing, you know, these protocols, you know? And it's like, well, you know, not deciding what to do is not an option, you know, and then not changing what we're doing when we figure out we're doing the wrong thing is also not an option. So like, you know, so we had, for example, multiple times a day. So, so some lessons learned on the good side of things, you know, we had a lot of good things, right? So we adapted the incident command and the emergency operations center. We did that very quickly. And part of that was because of the life care deaths. I've been working, actually, a number of us have been working. There'll be more stuff coming out about that, what happened in the early days. Will probably be a book somebody's going to write. 60 Minutes is doing an hour-long piece on, or not an hour, whatever, a piece on it. So there'll be some interesting stuff that comes out of how those things unfolded. But they were very good for us, right? Because everyone sort of got freaked out. And they're like, oh gosh, let's take this all very seriously. We also threw a lot of resources to appropriate tasks. You know, we're a big entity, right? 27,000 employees, a ton of money. And so we were able to really, you know, put appropriate resources into running out of time, appropriate resources into this. I will say that also I was very impressed by the level of skill of the administration and the chief administrators. So one of the things I always kind of was annoyed by these people that make, you know, $3 or $5 million a year for running stuff. And I was like, you know, how could that possibly be worth it from an institutional standpoint? I've completely reversed that. And what I realized was that these people at the very, very top, what they can do that the rest of us can't do is they can take these incredibly complex situations. They can look at it from different avenues. So for example, a big change in the hospital, they can look at it from the standpoint of the nursing unions. They can look at it from the standpoint of the employee wellness. They can look at it from a financial standpoint. You know, the clinicians, all of these different entities, interaction with different hospitals, with the feds. They can look at that, and then they can look at it with different variables in the future, and then they can talk about it all in real time, right? A normal person like myself, I could figure this stuff out. It'd take me a whiteboard, an assistant, and 2 days. Those people at the top, they can do it instantly, and it's really an amazing thing to see them at work. And I mentioned that in terms of strong definitive leadership, right? They made decisions, and they were accepting of other people's inclusive opinions, and they took all of this information, but they didn't get mired down. They made a decision. Can't say enough about John Lynch and Vanessa Makowitz, and these people did an incredible job. We could have done a better job at communicating what we were dealing with, because people, you know, got frustrated, you know, with the decisions and the lack of decisions. And so a little bit of transparency about how difficult the challenges were, I think would have gone a long way, particularly amongst the staff. And then we had a lot of plans that we just didn't use. A lot of reinventing the wheels. So if you don't plan, you're planning to fail, right? And then I would say also in disaster medicine, you know, it's a lot like emergency medicine. We just accept the fact that no matter how good a job we do, right, people are going to look at us and be like, yeah, well, it could have been better. It's like, whatever, you know, we have tough skin. You're going to be affected. In summary, you're going to be affected by a disaster. You know, we're beholden to ourselves and also beholden to the population that we serve to be as prepared as we can. And that includes preparation in your house and preparation in your work environment. And that's all I have. I'm always available. So, you know, the state pays me to be available. So please reach out and ask questions. And I have used up 3 minutes more of your precious time than I was supposed to. So maybe we can take questions by email. So
That sounds great.
Unless you have time for questions, I don't know.
There's 2 questions in the chat. Maybe we can adjust just really quickly, and then everyone can go to a break. But John chose asking, many of our residents go into primary care, hospitalists after residency. What should people take away besides having a personal home disaster plan as they become independent primary care docs or hospitalists? What can they do to be proactive in their own institution?
So I would say, you know, if you like the type of work, you can get involved at the hospital disaster committee level. So there's internists, there's hospitalists on all of our committees, you know, at some level. Each group has a plan as well. So, you know, right when you're starting out and you're just working on your clinical stuff, you know, just being aware of that plan, you know, and knowing what your responsibilities are in the event of a disaster event. So I would say that would be the easiest thing. You'll probably sleep better once you read that plan. And then once you realize that plan exists and then reading it, you're like, oh boy, I really should have known that. I'm glad I know it now. So, and then I can't see the chat. So what was the other question?
Last one's really quick. What was the textbook you mentioned earlier that you read?
Oh, it's just called Disaster Medicine. It's by Ciatoni. Don't buy it. It's like $175. So just send me an email and I'll loan you my copy.
Well, thank you so much. This was really very interesting and very timely, I think.
All right.
So
my pleasure. So
thank you again.
I'll be admitting everyone to your service, by the way, you know, in exchange for doing this. So
right. Fair
enough.
Right.
Thanks, everyone. Take care now.
Take a 5-minute break and then we'll come back for our next talk.